Okay, so good morning, everybody. Welcome to the 10th sessions for QHSC training. All this training are done before we come to our medical mission in 2 weeks. This is the second session for postpartum hemorrhage specific. And when we finish this training, we're gonna send 3 links for postpartum hemorrhage for that you have to review before we come to do hands-on training. The reason we have to put those 3 because we wanna make sure you get the background before we start skills evaluation. So when we come to Tanzania, it's not going to be a theory part, it's just gonna be hands-on from the beginning to the end. And so today's class is gonna give you just a summary of things that we're gonna be doing. And then we're gonna have a small meeting later on, we send a meeting for the facilitators just to make sure exactly how we're gonna evaluate during the phase training. So my name is Dr. Harit Gabone, and I'm CEO and President for QHSC. I am so excited and grateful that you guys are coming and learn with us. And we're gonna expect you to hear from you, get the feedback to make sure whatever we're preparing here with your colleagues, it's gonna be applicable to Tanzania. Postpartum hemorrhage is a huge thing. We're not going to be able to cover all these things for 3 hours. However, whatever the chance you can, just review those videos. We have a great team today. I'm just gonna give you just a little bit. We have a great team of presenters today. We're gonna have Dr. Gwen Randall from US, Mr. Jafari Lutavi from Muhimbili, Mr. Nicodemus from Dar es Salaam, also Muhimbili, Miss Agnes, I think her name is Ndunguru, midwife from Tama, and also we have a contributor for Dr. Mape Said Komba from Muhimbili. So all these experts are going to be sharing their experiences and then to try and enhance the training and make sure we get as much as we can from them. So I will encourage to have questions when they present, after they present their section, the specific area that we put so you can interact and get more information out of it. And then we can go as fast as we can and finish this training today. So without delaying, I'm gonna welcome Dr. Gwen Randall just to say hi. And then she's gonna come and present in like a minute or so. Dr. Gwen.
Good morning, everyone.
Good morning. Okay, Mr. Jafari, are you in there?
I'm here. Hello, everyone. How are you?
Good.
Yeah, good morning. And here is good afternoon.
Good, thank you. Thank you for coming here.
Yeah, as I introduced before, yeah, I'm Nicodemus Komba. I'm a midwife working with Muhimbili National Hospital. Also working with Tanzania Midwife Association as the Deputy General Secretary.
Okay.
So you're welcome. Yes, and also I am a master trainer on infection control and the maternal issues and the newborn as well.
Okay, thank you very much. And Mr. Nicodemus is going to share his experience and his prepare step-by-step how to clean the Nasg, which is one of the devices necessary or needed to provide stabilize the patient during the transport, so we can just go and to the higher acute level to be able to be taken care of. She is registered nurse and midwife for public servant from Atubungo district, and she's been working as a midwife for 7 years now, providing services to pregnant women, newborn, and youth-friendly reproductive sexual health services. So she is also one of our contributors, and then we're going to hear her when she gets in. Thank you, Ms. Agnes. Dr. Mape Said Komba, are you here?
Yes, I'm here.
Hi.
Hi, good morning, and it's good afternoon here.
Yes, good afternoon.
Yes, my name is Dr. Mape Said Komba, registrar from Muhimbili National Hospital, Department of Anesthesia and Critical Care.
And thank you very much. Dr. Mape is going to help us also to with a postpartum hemorrhage when you're in Tanzania hands-on session there. And I know the other two anesthesia also we're going to help us with the training. So thank you very much. So I'm going to let Dr. Gwen go back and start the training, and I'm going to stop sharing, and Dr. Gwen, you are next.
Okay. So good morning, everyone. As Dr. Gaboni was saying, we're really excited about this venture, and we really hope that the information that we share will help to guide and change some practices, and hopefully be able to save some of the lives that are being lost to obstetric hemorrhage. So the outcome would be to recognize postpartum hemorrhage, and that's the most important thing. Familiarize yourselves with these cognitive aids that we kind of use here in the States, and maybe you guys do as well, and be able to apply interventions to be able to manage these patients. Obstetric hemorrhage, it remains a leading and preventable cause of maternal mortality and severe maternal morbidity, a life-threatening complication during pregnancy. But also, it's not just a problem in Tanzania, it's also a problem in the US as well, especially with women of color. Maternal health in Tanzania, it's like 566 maternal deaths like every year out of 100,000 live births. And it's the 6th highest maternal mortality ratio in the world. So what are some of the challenges that are faced? And some of the challenges that there are inadequate quality of services, lack of access to emergency obstetric care, and there's a limited ability of women to independently access health services. The causes, as I think we've discussed before, with 70% being tone, 20% being trauma, 9% tissue, and then 1% throbbing. So the thing that we first need to do is we need to assess these patients. When a patient
Dr.
comes
Gwen,
on,
advance. I'm sorry.
Huh?
Advance your slides.
Oh, sorry. Wait a minute. Okay.
There you go.
Good. Okay. So the very first thing when someone presents to the unit, we can safely say that every patient who arrives on the unit is potential postpartum bleed. So we need to be prepared for that. So the very first thing we want to do is we want to identify risk. What are the level of hemorrhage risk and what actions do we need to take? So as we can see here, there's low risk, there's medium risk, and there's high. So with all of those things, basically you just start to develop a plan of action. So I guess one of the questions is, if you have a person who's coming in and you know this person is high risk, how do you start to prepare for that? And so a question that I had for the people in Tanzania, you can just put it in the chat box. And my question is this. Oops, hold on for a second. There we go. Do you have an OB hemorrhage cart in your unit?
But if you're able to respond, you can respond in the chat.
Yeah, respond in the chat, yes. And Harriet, you can tell me, Dr. Cavoni, you can tell me.
I'm still waiting. Anybody from Tanzania, do you guys have a hemorrhage cart? Or somewhere you put all your stuff for hemorrhage, for preparation for prevention of hemorrhage?
Chat 1, 2, 3.
Yes, they're saying yes, yes, yes.
Yes?
Yes. Mm-hmm.
Okay.
Dr. Mep said no, not on anesthesia side, no.
They don't? Okay. All right.
Yeah.
Well, just for the brevity of time, I'm going to share with you a hemorrhage cart, basically, and what it should have is everything supplies that you would need. Okay. It would have everything that you need, the supplies that would be accessible. So like on the units, for an example, from the anesthesia perspective, just like we prepare every day, when we go into the ORs, we prepare our rooms for our cases, the same thing should be for when you have OB. OB, that room should be always prepared, ready to go if you have an emergency. And so this cart should be part of that setup. Now, I don't know if you have the metal parts, but just to start thinking about any of you who do not have the parts, then this is the checklist from the CMQCC, which is a quality improvement toolkit, and basically it identifies everything that you should have in your cart. And I won't discuss everything because it's there. Now, what I would hope is that if you do not have a cart, that you would take this information and start gathering, documentation, and as well as gathering information about how you can get a cart, purchase a cart, make a cart, and have one readily available, because the drugs and everything should be there. This is just what should be in the cart. You should have a chart like you see here on the top, and that, like the one here, the chart here. Oops, sorry. You should have all the information, everything, all the drawers, everything that's actually in the cart, so it's readily accessible to everyone. Cognitive aids. Are you using cognitive aids in your units? And that's another question.
Anybody?
Nobody? Okay.
Can you
No
define what cognitive aid is?
Yeah, it's a thing that we use in crisis, where patient care essentially is developed, it's called for and examined. And so what it is that it's real life events that have happened, but what you do is, rather than standing there and try to remember, oh, who did what? Oh, did we do that? Did we do that? These cognitive aids basically are called like checklists, if you will. We use them in the United States all the time, and they decrease emission of errors. Errors are our #1 cause of death here in the United States. And so these are like charts, if you will, that you kind of just go through and you say, okay, did we do this, X, Y, and Z down the list? And so when we're doing simulated events, basically we are using checklists, and the checklists are based on these cognitive aids. So even I just attended a conference, a big AANA conference, and even at that conference, when we were going through and doing simulation, they always use checklists to make sure that everyone was doing what they should be doing, so that we would have a good patient outcome.
So Mr. Nicodemus and I think Dr. Hashim, they said yes, they do have that.
Okay, okay, good.
Is that for the cart or for the
No, cognitive aids.
cognitive? Okay.
Right. So, I mean, they should be in the unit. They can be on the cart, but they should be hanging, even if you don't have a cart, they should be hanging in the OB suite. So this is guidelines, excuse me, to just basically go through and talk about what should be done. And when the patient comes in prenatally, what are we going to do? We're going to examine that patient. We're going to try to identify if there's any kind of special issues that need to be addressed. And #1, we're going to perform a risk assessment. So once the patient is admitted, as you can see, we've identified a risk. And so what category is this patient? Then we go down the list here and you say, okay, well, stage 0. Stage 0, normal delivery, no problem. Patients have no issues at all that we really need to be concerned about at this time. But if the patient is bleeding, for an example, then we would go down to stage 1. Stage 1 would then, we would do the standard steps. So what I'm saying here with this kind of a chart is that when we're doing the simulation, I want you to be familiar with all of these steps that are in here. So then when we actually go through and do the simulated experiences on site, we will be using checklists, and then the checklist will identify whether or not you have familiarity with these. Again, this is basically just a flow chart, and the flow chart from the time the patient is admitted, how the patient goes down to the different stages. If the patient is stage 0, that's all birth. If the patient is losing blood, stage 1, how much blood has the patient actually lost? Stage 2, if they've lost a liter or greater than a liter, is stage 2. And then there's certain actions that go along with that. If there's a vaginal birth, then what do? You do a fundal massage. If the fundal massage is not working, then what do? You want to look to see if there's potentially POCs. And then if it's a C-section, then that's a whole different ballgame in and of itself, because you want to try to control the hemorrhage and urine atony litigation. And so at that point, you could probably use a balloon. Now, if a patient has blood loss of greater than 1,500, then the patient most likely has some kind of coagulopathy. And then we're going to be thinking about taking that patient to the OR, maybe even sooner. So if we just follow along here, and you'll see if yes, then we have an ongoing assessment for stage 1. If it's stage 2, where the patient has actually started to bleed, then there's certain behaviors. First of all, do you want to call for help? You should always call for help in that stage. And then that starts the whole cascade going down. Should always call for help. You should always call for help. And if the patient is in stage 2, basically, then you should have blood available at that time, and be thinking about transfusing the patient, as well as identifying all the costs, all the causes that are associated with it.
I'm going to add, sorry, Dr. Gwen, I'm going to add those charts and guidelines is going to be shared with the video and link, so you can have more time to read, because all those things we've compared with you guys who are Tanzania, your protocols, the call for help, the stages are the same, but Dr. Gwen is adding more content to those areas to know for sure and create consistency. Like every single person should be thinking the same thing on that time when the event happened.
Right. Right. And it's really about standardization. As we talked about, doctor hospitals should really be thinking and doing kind of the same thing. One hospital shouldn't have their own protocol, another hospital using the government protocol, and another hospital using whatever. I mean, it should be standardized across the country. And pretty much in the US, we use these checklists for OB emergency management. And you can pretty much go from one hospital to the other. We're all using ACOG regulations and recommendations, evidence-based practice for what it is that we do. So the standard is pretty much, no matter where you are in the country, if you're doing OB, these are the standards of practice for OB in all of our 50 states, pretty much all around the country. And so the same thing, we hope will, after all of this training, will help to standardize some of the practices there in Tanzania as well. Now, when you actually are going through the simulated experience, then we have to have some kind of way to check you off. Okay, do you really understand what it is that you're doing? Are you going through the right steps? And so if you think about it, these are what we're going to be using to evaluate you. So if you go back to, the obstetric emergency flow plan and you familiarize yourself with that, then when you're actually doing the simulation, you should be able to go through these initial steps. Or what are you going to do? Are you going to call for help? What meds are you going to need? What stage is the patient? So we always evaluate what stage the patient is in. If it's stage 0, stage 1, stage 1, 2, and 3 all call for different behaviors. And so with this checklist, we want to make sure that you understand where the patient is. The patient is bleeding, then what do you have to do? What steps? What medications are you going to use? And I know that there's some of the medications on here, maybe medications that are not used in Tanzania, but you can certainly improvise. And so if the patient is bleeding, then what are the steps? You're going to call for help. The patient's basically, here, if a patient comes in and anesthesia evaluates that patient, most of the time the patient if they don't have a running IV, they have a MAP, which basically is an IV access. If a patient starts to bleed and the patient starts to clamp down, the likelihood that you're going to be able to get 2 large bore IVs in that patient are nil and none. So if you start with, just having a map, if you need it, fine. If you don't, then that's fine too. But I think having an IV access early on is a key in patient care. It talks here in the second stage about placing a second IV. Well, you have to have a first one in the beginning. The other thing from my conference this week, it talked a lot about if you don't have access to blood, then you can use TXA. And I think, do most of you in Tanzania, do most of the facilities have TXA available? You can put it in the chat, please.
I see Dr. Mugari saying yes, Dr. Mape say yes.
Okay.
And I think Dr. Hashim said yes, is available.
Okay, good. Then that's great. Because TXA, you can give 1 gram initially over 10 minutes, and then it can be repeated up to 2 grams, which, some people do, some places do, and some people don't. But the key with TXA is to get it on board early. It's not something you wait until the last minute and then you start to use it. If you know that you're going to potentially, if you're having a problem, the patient's bleeding, you know that you don't have blood readily available, then what can you do? You can use TXA and other maneuvers, which we'll talk about, and using the mask garment as well. Okay. Also, you can do a patient could potentially ended up having a hysterectomy. And then stage 3 is if the patient is continuing to bleed, you're going to do all these things and with the medication regime. But again, you can repeat the TXA. And stage 4, patient is in cardiac collapse. And so it's a whole different ballgame at that point. It's mass transfusion protocols, which you may or may not have. And so we kind of go from there. Okay. All right. So that's my portion. In the brevity of time, since we have so many other speakers, that's my presentation for this morning.
Thank you.
Thank you.
I know Mr. Jafar is not here. Any quick question that you guys have for Dr. Gwen before we go to the next? I know
And all
Dr.
of these, and we're preparing to make these. I think we're doing laminates, right?
Yes.
We're doing laminates for all the departments. So when we come, we'll have these things laminated for your units.
Yes, so we are going to share more information and how to assess or evaluate skills with the facilitators so they will know exactly how to walk you through the steps. But also you should be familiar with those steps, what is required of, and it will make it will be easier and consistent for every single person who attended those training. Dr. Mape Said, anything from anesthesia standpoint that you can add right there?
Okay, thank you for your nice presentation. On the side of anesthesia, first of all, I wanted to ask.
Yes, go ahead.
If the protocols or cognitive aids, as you say, that you are using, are they incorporating that they are used by both OBS and GYN surgeons and anesthesia, or these two departments have separate cognitive aids or checklists?
No, they're combined. They all pretty much use, because some of the nurses, so for an example, when the patient starts to bleed, the nurses are the ones who start to identify that. And so it's used throughout, with the nursing staff as well as the anesthesia staff. Anesthesia staff gets involved. I mean, it depends. So some of the units, they have anesthesia on call in the unit 24 hours, 7 days a week, especially in the training facility. So at that point, anesthesia is more actively involved. Then other places have anesthesia pretty much on call, then the nurses are responsible to initiate, if you will, this checklist going down, you know, when they need to call for help and that kind of thing. So it's used sort of like worldwide, or it's used facility-wide, where everybody's involved in it, not just anesthesia.
So also for Tanzania, I think what Dr. Gwen is saying, when you admit that patient, so the patient shows up, so you have to start staging them in the beginning, even before they bleed. And then so you will know for sure if this person needs immediately IV, or is it 1 IV or 2 IV, from what the patient's history is. And I believe one of the discussion when we with Dr. Mugaru, we discussed about how to identify, and I think from Wananyamala, they had a routine that if the patient comes in, they know what exactly the steps to go through, and then you know if this patient require more acute versus standard of care. So those are things that we want to emphasize. If the patient comes in, you have to be able to put them in a group. Okay, this is going to require A, B, C, D. Then you have to identify them and make sure those resources are already available before she starts bleeding. Because we all know if the patient has started bleeding, it takes very few minutes, 4 or 5 minutes, you can lose them out, because they bleed from everywhere. So we need to be able to prepare and identify them before they bleed. And then so from then, do we have another person for questions? So I can go to Mr. Jafari. I don't see Mr. Jafari there.
No, I don't have just an emphasis.
Okay.
Yeah, yes. What I've seen, you know, PPH is likely to be controlled when you do an active management of steady stage of labor. But in our facilities, most of the time you could find that the oxytocin used for the active management of steady stage of labor is not stored properly. So that's just a master of emphasis when you be delivering the training that to the participants, that they should consider it. There are some heat stable, but some they are not heat stable. So as if you don't place them in a good condition, they lose potency. But also the issue of postnatal, you know, postnatal care, even even now we don't have the guideline. So most of the postnatal care are not good. So you would find some mothers are getting PPH when they are disposed at that postnatal ward. So and those happening there are getting too complicated. My mothers will die. So also there's some sort of emphasis on postnatal care in terms of management of postpartum hemorrhage, and early identification has been narrated by Dr. Gwen. Thank you.
That's an excellent point. Definitely. That's what we want to say. As soon as you get in touch with this pregnant woman who is going to be in labor, definitely we need to be able to do that. But if during the prenatal care, they come to the clinic, the doctors or the midwife, whoever is seeing that patient, they are going to know they have risk factors. So those patient needs to be identified even before they get into the labor. So if you know for sure this patient is preeclamptic or diabetic, and I mean, we have a long list, then you know for sure when she gets into labor, the note should be identified that, okay, this patient has this risk. Maybe they already passed the stage 0. More likely you're going to do this first stage and second stages. I mean, those are things that we are hoping that early identification, early screening is necessary. So for that patient to get to be active.
Yes, identifying the risk is very, very important. And so what we say is every patient that presents is a potential hemorrhage. And so we treat those patients as such. And so being able to identify their risk factors up front, put them in a category, and from that category, what do you be prepared to do? Okay, and we're hoping with all of this training that that's going to, but again, the nurses need to be involved in this as well. Very much so.
Great.
Okay, great. So
Okay, on the part of working as a team,
yes,
I think on our side, if we take anesthesia as a table with 4 legs, 2 legs that are very important to us, it's lab and the pharmacy. Do we have these members in our team from lab and pharmacy? Do we have them?
Well,
in training? People's from
Oh.
pharmacy and lab.
Oh, you're talking about
No.
engaged in this training?
Yes,
No.
because we really need them to participate. So if we plan to make a checklist or a protocol, it could be easy to have a main decision, because most of the time blood and the bloody products will depend on the lab, and most of the uterotonics and the medications will depend on pharmacy.
Yeah.
So you might ask for something and it is not available just because the pharmacy are not aware of the problem or the issue, things like that. For us, it could be easy if they participate. At the end, we have the same goal.
Right. So one of the things where I know that you want to have pharmacy involved, but one of the things that you can bypass is if you have that OB hemorrhage card, the drugs that you would need would be readily available to you and you're not pharmacy dependent. Like, and so then you would need the lab for bloods. So having that hemorrhage card will help you a lot with, you know, the drugs that you need right up front quickly.
And I think more discussion will continue definitely after the training, but still during the training, Dr. Maple, this is an excellent idea, including all the discipline to be involved, because postpartum hemorrhage is not an OB issue. No, it's not.
Right.
It's everywhere.
Right.
So those are the great questions that we need to include. And then, of course, we're going to try to push and add more discipline as much as we can, even after the training, especially when you come for the implementation of those cards, or even if you don't have the card, just even the tab to put the your supplies ready to go. And everybody should know where it is. Okay, so I'm going to connect to the next part so we can get going here. So Mr. Jafari was supposed to come and help us because part of the training, we're going to use the Mama Natalie or Mama Yu to show the demonstration of postpartum hemorrhage. And then so since he's not here, we're going to use this video. It's a real short video just to how to apply. So in each unit, people should be able to use. So if this patient and we can control the bleeding, so what is next? Dr. Gwen, you wanna go back?
So I think this is where it is. All right.
Yes.
So, essentially when you see that you have a large amount of blood, you're really not going to hang around and wait for lab results. And we're going to be thinking about what do we need to do, want to intervene early, and we don't want to delay, especially if you know that the patient, you don't have the, I guess you don't have the ability to care for this patient. The patient needs to be transferred to another higher level facility. Then what can you possibly do in the meantime? And in the meantime, you can use, and we're hoping we're going to have these available, is something called non-pneumatic Anti Shock Garment. This is a first aid device. It kind of compresses the lower body, and it has 9 articulated segments, closely tight around the legs. It pushes the blood up the pelvis and into the abdomen. So there was a study that was done in Zimbabwe and also Zambia, and actually they looked at the use of these non-pneumatic garments, and they found out that 45% of the women who, when these garments were used, had much better outcomes in terms of morbidity and mortality. So the key is we want to tamponade the abdominal and pelvic and uterine vessels so that you want to minimize the blood loss with these patients. And so the garment itself, this is the garment and how it's placed. And so it's sequentially, it's 1, 2, 3, 4, 5. And then basically as you want to decrease the blood loss, and when it's systematically, they're taken down systematically as well, depending on the level and depending on the patient's condition. But this will certainly buy you time to go from point A to point B, and there really are necessary garments. So what happens is that there's a circumferential compression. It kind of decreases the vascular tone, increases the preload, PVR, as well as the cardiac output, and hopefully, to get the patient from point A to point B where they can get blood for the required treatment that they need. And I have a video here that basically demonstrates the use of the garment.
Hello, citizens of Internet. Today, I am going to talk at length about a first aid device called Non-pneumatic Anti Shock Garment, NASG, which is used for initial treatment of hemorrhagic shock in obstetrics, especially in acute postpartum hemorrhage. Currently, it is the only medical non-surgical device available for stabilization of a patient in obstetric shock. Please note that this is an adjuvant therapy to other medical and surgical treatments of hemorrhagic shock. It is a lightweight, washable, reusable, and relatively inexpensive garment made of neoprene and Velcro that resembles the lower part of a wetsuit. Neoprene is the same material that is used to make suits worn by astronauts during space travel. As shown in the picture on right, the non-pneumatic anti-shock garment is designed in 6 horizontal segments, with 3 segments on each leg, another segment over the pelvis, and a segment over the abdomen. Segment number 1, number 2, and number 3, which are paired, are wrapped tightly around patients' legs, calves, and thighs. Unpaired segments number 4 and number 5 go around patients' pelvis and abdomen, respectively. Segment number 5 contains a small, foam compression ball that lies over patient's umbilicus, belly button. Its function is to compress the atonic uterus. As shown here, segment number 6 overlaps and is wrapped over segment number 5 and fastened with Velcro. As shown in the picture, knee joints should be free and lie between segment number 2 and segment number 3. This allows attending obstetrician to give the patient lithotomy position, to check for degree of bleeding and perform other procedures like insertion of tamponade balloon. The mechanism of action of this device is as follows. It provides circumferential counterpressure that overcomes pressure in capillary and venous systems, 15 to 25 millimeters of mercury, which effectively reduces bleeding from lower half of body. The tamponade affected creates pumps blood that has pooled in the lower part of the body to upper half of body that resides vital organs like heart, lungs, and brain. This results in translocation of up to 30% of total blood volume from lower body to core body organs. Thus, it decreases bleeding and reverses shock. It may arrest bleeding and avoid surgical intervention. It may decrease need for or number of blood transfusions. It may contribute to decreased morbidity and mortality. It can be deployed in situations where patient is hemodynamically unstable, for example, atonic postpartum hemorrhage, traumatic postpartum hemorrhage, road traffic accidents, etc. It can be used in men too. When the patient to whom NASG has been applied has to be transferred to a tertiary care hospital, a strict protocol must be followed. Informed consent must be taken. Check availability of bed/doctor in the referral hospital. Referral documents, including baseline vital parameters at the time of transfer, indwelling catheter with Eurosac, vaginal pack in traumatic postpartum hemorrhage, record presence of pack/tamponade, do not remove until destination. Paramedic/doctor must accompany the patient in the ambulance up to hospital. Anyone with a little training can apply the garment to the patient. It does not necessarily have to be a medical doctor. Not only a nurse or a paramedic, but if required, in rural areas, even an ambulance driver or attendant who is trained can apply it. Application takes 2 to 3 minutes. The following video demonstrates correct technique of application. With the garment placed in open position, put the patient in supine position, with her spine over the dots in the midline of the garment. First apply segment number 1 over lower part of leg on either side. To check that the application is tight enough, insert the index finger inside it and pull the finger out. A snapping sound suggests that it has been applied correctly. This is called snap test. This test should be repeated after application of each segment in a serial manner. After application of segment number 2 and number 3, ensure that patient's legs can be flexed easily at the knees. When applying segment number 5, ensure that the foam lies over the uterus. Then wrap segment number 6 over it tightly. Entire application takes 2 to 3 minutes. Before removal of NASG, certain criteria have to be ascertained. Bleeding has stopped or has reduced to less than 50 milliliters per hour. Patient's pulse and blood pressure are stable for at least 2 hours. Before removing each segment, wait for 15 to 20 minutes, and then check patient's pulse and blood pressure. If there is no increase of pulse and/or fall of blood pressure by more than 20, then the next segment can be removed. If at any time pulse and blood pressure change by 20, rapidly close all open segments and look for source of bleeding. This is called Rule of 20. Also, ideally, the hemoglobin level should be greater than 7 grams percent or hematocrit 20% or more.
There is one situation where the garment can be removed without meeting above criteria. This is when patient is in the operation theater and is ready for emergency surgery. Removal has to be done in a stepwise manner by a qualified medical person, such as an obstetrician. As mentioned earlier, first ensure that bleeding has stopped or has reduced to less than 50 milliliters per hour, and patient's pulse and blood pressure are stable for at least 2 hours. Wait for 15 to 20 minutes before removing next segment. After 15 minutes, check her vital parameters again. Watch for renewed bleeding, if any. If her pulse and blood pressure are stable, and there is no fresh bleeding, go ahead and remove the next segment. On an average, removal takes about an hour. As this garment is reusable, after its successful use, it should be cleaned, sterilized, and then stored in clean dry place. First, place it under a tap with running water to remove blood and blood clots. Once it is cleaned, dip in a hypochlorite solution for 20 minutes. Wipe it clean, dry it under sunlight. Then fold it properly and store in the bag provided, till next time it needs to be used. In the last part of this e-lecture, I will answer some frequently asked questions. So, here goes. Who can apply it? Anyone with little medical knowledge, for example. Nurse, paramedic, even an ambulance driver, can apply it to a patient. What is the maximum time for which it can be worn? Although there is no hard and fast rule, it can be worn up to 48 hours. A commonly asked question is, how many times can one reuse it? On an average, one garment can be used up to 30 times. Does it come in different sizes? It is available in 2 sizes, small and medium/large. An important question, how much does it cost? Well, in India, it costs about rupees 8,000. It is manufactured by a company called Visco. In USA, it costs about $160. Someone asked me a peculiar question. How much does it weigh? Luckily, I knew the answer, 1.5 kilograms. I will conclude with a peculiar question someone asked me. Which color of garment do you like? My prompt answer, for anything that is wrapped tightly around, whether for men as well as women, I prefer pink. Pink for prevention.
So with that, after receiving that, after using the NASG, how do we clean it? So Mr. Nicodemus is gonna help us. How do we clean this garment? Are you ready, Mr. Nicodemus?
Yeah, yes, I'm ready.
Okay, go ahead.
Yeah, as you know, this is not new, that we have discussed it last week. It's just a matter of, it's just presented in a formal way. So you can go on. Yeah, so this is, as we discussed last week, that is the fabric material that should be in a hospital facilities handled like other linen. So even the handling of it, the processing and the storage and transportation is the same. It goes the same cause as the other linen. So what is most to be remembered is there must be sorting, so as to notice those foreign bodies and dangerous objects like sharp, so as they should be removed before you start processing it. And soiled linen, soiled Nasg should be processed within 24 hours. So it should not pass after 24 hours before you process it. So go ahead. So the steps on processing of the Nasg is, first step is pre-wash. So you immerse the Nasg into a soap water bucket and you wash it. You make a friction so as to remove the tissue particles and other debris and other contaminant. And then after that, you rinse it with clean water. And then after that, you squeeze. And after squeezing it, you then, sorry, this process, a pre-wash, it removes up to 90% of microorganisms. Go ahead.
Yes, I am. But why?
And then second step is disinfection. You soak the Nasg into the chlorine solution at 0.01% for 10 minutes. And then you wash it and rinse it with soap water, followed with clean water, which is cool. So the intention of soaking it into the soap water is to remove the chlorine solution, the chlorine residue in the Nasg, because if it could remain, then it could cause some damage in Nasg. So, but here there is some contradiction. So if you read some guideline here in Tanzania, you will find that the chlorine solution strength should be 0.05. But for when you read the manufacturer of the Nasg, they just recommend 0.01. So I was decided to take this manufacturer as instructed by the manufacturer. So when you go to step 3 is drying. So you squeeze and then you let it dry in a cool area where there is no access of direct sunlight. And then in Dar es Salaam, it can take maybe 1 day to dry, but to some places it could take more and longer days. Yeah. So then you store it. Then it is highly recommended that the healthcare facilities shall maintain at least 1 Nasg stock level. So after cleaning and when it gets dry, then you store it in a non-porous clean shelves cupboard. And if it is not used for 3 months, then it should be reprocessed as it is used. Yeah, that is it.
Okay, thanks. So Mr. Nicodemus is gonna help us. How do we clean this garment? Are you ready, Mr. Nicodemus?
Yeah, yes, I'm ready.
Okay, go ahead.
Yeah, as you know, this is not new, that we have discussed it last week. It's just a matter of, it's just presented in a formal way. So you can go on. Yeah. So this as we discussed last week, that is the public material that should be in a hospital facilities handled like other linen. So even the handling of it, the processing and the storage and transportation is the same. It goes the same course as the other linen. So what is most to be remembered is there must be sorting, so as to notice those foreign bodies and dangerous objects like sharp, so as they should be removed before you start processing it. And soiled linen, soiled Nasg should be processed within 24 hours. So it should not pass after 24 hours before you process it. So go ahead. So the steps on processing of the Nasg is first step is pre-wash. So you immerse the Nasg into a soap water bucket and you wash it. You make a friction so as to remove the tissue particles and other debris and other contaminants. And then after that, you rinse it with clean water. And then after that, you squeeze. And after squeezing it, you this process, a pre-wash, it removes up to 90% of microorganisms. Go ahead. And then second step is disinfection. You soak the Nasg into the chlorine solution at 0.01% for 10 minutes. And then you wash it and rinse it with soap water, followed with clean water, which is cool. So the intention of soaking it into the soap water is to remove the chlorine solution, the chlorine residue in the Nasg, because if it could remain, then it could cause some damage in Nasg. So, but here there is some contradiction. So if you read some guideline here in Tanzania, you will find that the chlorine solution strength should be 0.05. But for when you read the manufacturer of the Nasg, they just recommend 0.01. So I was decided to take this manufacturer as instructed by the manufacturer. So when you go to When you go to step 3 is drying. So you squeeze and then you let it dry in a cool area where there is no access of direct sunlight. And then in the lesson it can take maybe 1 day to dry, but to some places it could take more and longer days. So then you store it. Then it is highly recommended that the healthcare facilities shall maintain at least 1 Nasg stock level. So after cleaning and when it gets dry, then you store it in a non-porous clean shelves cupboard. And if it is not used for 3 months, then it should be reprocessed as it is used. That is it.
Very much, Mr. Nicodem, for the processing and sterilizing the garment. We all know that any device or instrument that with the body fluid, then definitely we have to worry about how you process it. And the process has to be consistent to make sure we keep it clean and safe for the next patient. And then so the logistic has been made right now to make sure each hospital, the ones that we're going to be doing the training, at least we have 2. And then Muhimbili might have 6 to 8, or depends on what how many we secure them. So the idea is like if the patient is coming from Buguruni, should be on the NSG, goes to to Amana. So Amana, either they have a clean one to give to the person who brought them from Buguruni, so the Buguruni will take that one back just in case the next patient needs it, it's readily available. And then of course the same thing for Amana, if Amana needs to transfer that patient to Muhimbili. So when Amana gets to Muhimbili, Muhimbili should be readily available and be able to give them a clean one to take them back, because every hospital should have those NSG ready to go so they can be used for the next patient. And of course, we know we want to make sure the first patient is safer and the second patient also is safer, and sequence of those patients. The logistics are being made right now to make sure who is going to be responsible. And I remember, Mr. Nicodem, last time we did discuss, can you answer that for the people who are not there? What's your recommendation? Where should it be, and who is going to be responsible for those NSG in the local facilities?
Yes. Pardon, Harriet. I just got a problem with internet connection.
No, I was asking, I said the last time you shared where is the available area that you should be the NASG placed for the next person. So instead of putting them in storage or in cupboard and locked away key, where should they put it to make sure when they bring the new patient, then they should be able to have one readily available to hand it back to the escorting team? Do you remember that discussion?
Yes, I remember.
Mm-hmm.
I remember, but as we agreed that that once maybe the Buguruni come to Mwananyamala, they will make sure that when they escort the patient, they will leave it there, the dead one, the used one, and then they will take the processed one with it to Buguruni. So it is, in fact, the processing area will be the center of referral of this Nasg. Because once the Buguruni get back to their facility, they go back with the processed one. So once they go there with the used one, then so it's like a process center is there. So what they should maintain maybe in Buguruni is just how to store it properly.
And wait for the next patient.
Yeah.
Yes, Dr. Msambichaka, you have raise your hand.
Yes, thank you. I'm sorry I missed most of your presentation, but I just caught the last part of it. And it looks like at the very bottom, you say if unused after 3 months, it should be disposed. Did I catch that correctly?
No. It's not disposed. It should be reprocessed.
Reprocessed.
Reprocessed. The issue of cleaning, it should be cleaned as it is used, because this is just a matter of microorganisms. So because of the exposure of microorganisms and so forth, after 3 months, it is like it has already contaminated to the threshold that is equal to that one who has been used. So in order to minimize the rate of contamination, so you need to reprocess it again, so it becomes free from contamination. You know.
Okay,
so
thank you. I was like,
yeah, because it is very riskier because it could act as a media of transferring microorganisms from one patient to another, and this patient is bleeding all over, so it's very easier to be invaded by microorganisms if it is not well processed.
I appreciate that. My heart sunk. I was like, this is an expensive venture if you have to replace it every 3 months if unused. So thank you so much. I appreciate your clarification.
Thank you.
Yeah, we'll be out of business, Dr. Msambichak. Yeah, so Dr. Mugaru from Mwananyamala, how do you see this process of if you guys get those NASG, and which is you think, on your opinion, which is the area that you think is going to be the best to be stored, so in case of emergency to be used, and then when you bring the clean one, where should we be located? Dr. Mugaru?
Hello.
Hi.
I support the discussion. I think the non-pneumatic shock garments would be very helpful in transporting and management of hemorrhagic shock in obstetrics. I was proposing that the best area to be stored is where everybody will know the location and it will be easily accessible to every member. For example, in the cart that Dr. Gwen showed in the beginning, can't it maybe be stored somewhere like that? At Mwananyamala, we have such a cart. If we don't know how large it is, but if it was, maybe it can be compressed into a smaller part. We don't know how it actually looks. So if it can be easily carried and stored in such a cart, and then in event of PPH, everybody knows everything is in the cart, including the non-pneumatic shock garment. Thank you.
That's a very good idea, Dr. Mugaru. Yes, it's small enough that it can fit or hang next to the cart if you do have the cart, and depending on the size of the cart, the proposed item, you can see the quantity varies, like maybe 8, 10, or whatever. And it also depends on your number of patients, possible postpartum hemorrhage patients in a day. So let's say the unit has probably 15 deliveries in a day. I'm just exaggerating, 15 deliveries in a day. So you should have at least 2 or 3, one cart for probably 2 or 3 patients for that delivery in a day. So 15 deliveries, so you should have at least 5 carts, postpartum hemorrhage cart, because we know in labor and delivery, you can have 4 or 5 delivery in 1 hour or the same hour. So you should have carts standing by for those patients. And then, so if you have multiple carts, it's easier to reduce the number of quantities if you don't have the size of it, and then you add NSG in one of the carts, and then everybody knows where it is. So that could be also by looking at the list and see if we wanted maybe 5 IV bags in each. So you can put 4 and then add more stuff because you don't have space. All those things can be adjusted to fit your unit, but recommendation is to have an adequate number according to your sensor. Then it should be those recommended number of supplies. So that's a great idea to put it where it's supposed to be, more like it's in labor and delivery where you're receiving patients or sending a patient out from. So those carts should be readily available. Everybody should check on the beginning of their shift to know where it is. Is it restock? You can have an itemized log to say, okay, at 8 o'clock, so-and-so is checked in to make sure items are in there. Anybody who use it, make sure you check it back and check to make sure all the items are replaced. Or if maybe the nurse or the midwife who doesn't have time, or the person who is in charge doesn't have time, give maybe MA, to make sure they have that list, but still the nurse should come back before you put it in use. You have to make sure those items are in place. Here in United States, we have those checklists twice a day, like in the beginning of the 12-hour shift. And then every time you break that seal to use it, you have to be able to seal it back by adding all the equipment back in there to make sure it's ready for the next patient. Let me see who else we have. Hashim, any comments about the carts, the NSG cleaning process? Where do you recommend it should be placed?
Okay. Hello, everyone.
Hi.
Hi, my name is Hashim Yatera. I'm midwife. I'm from Loganzila, Muimbili.
Yeah, great.
Yeah. So
Okay.
for me, I think the place where should be stored or processed it is in those referral hospitals, because as you know, are the one who receive those patients. So it is better if there are many there. So for those who come with it, and they'll get you new one. I mean, clean one.
Mm-hmm.
Yeah.
Yes, so the receiving hospital, the referral hospital are going to have more than, I mean, I believe during the discussion, one of the discussion, you said 6 to 10, it depends on the availability, how we can secure and get them there. But then the other health centers, we have at least 2. And if we get a bigger quantity, then it might be more if you have a increased number of the deliveries, and of course, number of patients who are experiencing postpartum hemorrhage. So all those factors are going to play to see how many do you need, like on the bare minimum, how many do you need to start with to be able to run this process?
Okay. So I just want to remind you, if you said like in Muimbili, don't forget about Mloganzila. It is in Muimbili too.
Oh, I thought if we say Muimbili, you're included in there.
Yeah.
Okay, no, it's good to know. So definitely we make sure when you are discussing, when we say the Muimbili, be like, okay, what about our friend from Mloganzila? So
Okay.
thank you for bringing it up.
Okay. Thank you.
You're welcome. Dr. Sangalala, any comment from Amana's standpoint, the location, who is going to be in charge in that area, or how do you see that process for those NSG?
Hello.
Hi.
For NSG, I think they can be put in labor ward, where most of the time we're getting the PPH patient, and also to the postnatal wards, post Caesar, and together post SVD wards. So for us, I think we are having 3 places: post Caesar, post SVD, and in the labor ward.
Okay, so for the C-section. Okay. And for just a quick number, do you know how many, I mean, just estimate, how many deliveries you might have in a day? Do you know?
Currently, having a normal delivery, you can go up to 15,
okay.
And cesarean section, you can go up to 12 in the 24 hours. So
wow.
Our delivery range from 25 to 30 per day.
Oh my goodness. And you think 2 NSG will work?
Yeah, they can work, because not much we are getting the PPH patients. Because whenever we are getting them, we are active in managing them. So a few of them, they go to complicated cases, but so few of them, they'll even 2 to 3, because most of the time we are receiving those who are having already PPH. So I think the lower facilities, there's a place where they need more.
Okay, now that makes sense, definitely. Now I'm glad if you're actively managing them to prevent the shock. Yes, that is great. That is the best preventative measure by being active and identify and screening patients before they get there. So that is great.
Yeah, thank you.
Oh no, thank you. Dr. Mugaru, how many do you get, you guys, for Mwananyamala in a day? Just an estimate, just for logistic purposes.
Currently, we get about this similar rate to the previous speaker, so about 15 to 10 deliveries, normal spontaneous vaginal deliveries, and we could get about 4 to 5 cesarean sections, but it's seasonal. So in the past month, about around March to around May, we were getting about 20 to 30 deliveries, normal deliveries in a day, and sometimes more than 10 cesarean sections in a day.
Wow, you guys are busy. And then so for out of that number, do you see how many people and might need to be transferred from Mwananyamala to Muhimbili? Just a guess.
Transfers to Muhimbili due to PPH are not that often.
Okay.
So we could transfer maybe 2 to 3 patients in a week. Very few people. And currently the rate is very low transferring to Muhimbili.
No, that tells me that you guys managing very well. So that's great. So we're probably going to need to learn more of your best practice to make sure we standardize and make sure everything works. Okay, so thank you for sharing that. Dr. Msambichaka?
Yes, I have a question for either Amana or Mwananyamala. How often, like, what's the rate of transfer from, let's say, Buguruni and the lower hospitals to your hospital? Like, how often do you get patients directly to you versus them going directly to like Muhimbili? Because I'm assuming there are times that they bypass you depending on the degree of hemorrhage or shock that's going on.
I think that's Mwananyamala or Buguruni. She's asking the question. Oh, Amana, sorry. Oh, Mwananyamala.
Hello. For Amanda, we are having the WhatsApp group where we are communicating whenever we are having the patient who is having PPH or is in need of specialist consultation. So whenever we are having the kind of the patient, sometimes we call them straight to Muhimbili so they can help the patient straight. But for those who we know that according to our setting, we can have the patient, then we are receiving the patient here at Amana, and then we manage them accordingly. So you can find per month, you can have maybe PPH cases, maybe 5 of them, or which are too bad, you can find only 1 or 2 will need a consultation from Muhimbili.
That's wonderful. Harriet, that means that maybe the 2 might actually be adequate as a start.
Yes, exactly.
Yeah, 2 will be enough. Yeah.
Okay, no, perfect. Thank you. I think Mwananyamala did answer that. They said what, 2 to 3 per week, so that's excellent. Either Nicodem or Dr. Mape, in Muhimbili, how many patients have you received? Like, I know you're receiving from other hospital, hospital in the region. Like in logistically and estimation purposes, how many do you think you receive in a day or in a week, if you know? This is just for estimated purposes.
It's a bit tricky.
Yeah.
It's a bit tricky, but we receive many. You know, most of the referrals that we have here are them from those lower facilities.
Yes.
So to say how many per week, I might not be sure. Maybe Hashim could help.
Okay.
Yes.
So it depends with availability of blood products.
Yeah.
You find that if there is scarcity of blood product, then the referral, there will be many for PPH because for reason of blood product. Even if Morogoro, they'll refer to us here. So at least 2 to 1 per week in average.
Okay, so that's a good number. I mean, if you
for case of PPH, isn't it?
Yeah, in case of PPH.
Yeah.
Not other referrals. Yeah, that's good.
No. Yeah, we're talking just PPH.
Just PPH only.
Yeah, because we're trying to find the if we're discussing and say how many should they be standby at Muhimbili, we need to have the idea just in case every hospital around there, those within those 6 regions, send their patients. So if somebody is sending either 1 or 2 in a day, and then we add to maybe Mwananyamala, we send 1 or another hospital is going to send one. So he said Muhimbili at least should have close to 1.5 of the number that they're expecting on that day. In order to, if every hospital send in one day, then you should be able to exchange and left with a couple of them. And you know, in labor and delivery, seasonal change, like what Dr. Mugaro just said, you might have 15 to 20 delivery today, and then there's a month you go up to 30 because everybody decided to have a baby, which is great, job security. So those are things that we want to be able to know logistically to estimate initially. So we don't want to underestimate, also we don't want to overestimate, because those things are not cheap. But for the sake of the patient's safety, we want to make sure at the bare minimum, we have the accurate number to be able to address that transition from one hospital to another. So you're taking one patient here, then they should get that NSG as needed, and then transfer that patient. So that was great. Dr. Gwen, do you have anything to add? Question to our great doctors, nurses, and midwives here?
No, I don't have anything else to add. I think it's been a great discussion, and I think that, you know, we know each facility needs at least 2. We know that. Yes.
Least. Yeah. And then, and Muhimbili, we need 6 to 8.
I think that, you know, we can't stress the importance of this enough in terms of life-saving mechanisms, because you know, the outcomes have been great in terms of that study that was done in, you know, Zambia and Zimbabwe. So, I mean, the evidence is certainly there.
Yeah, so I mean, thank you, Dr. Gwen. I think, yes, before the training, we are going, I think somebody asked you in the chat. Yes, we are going to send the video. So there will be 3 links of the video regarding postpartum hemorrhage. We did one session before. This is another session, and then Dr. Gwen is gracious enough. It's going to do another recording, and then so we're going to create those. Will be 3 links for the YouTube, and then we're going to share those ones and try and watch them and listen to them and understand. So when we get there in 2 weeks, we have an understanding when we're trying to do clinical application, so we can get the most out of it. Because when you're reviewing that content, you have any question, please send out those questions to Dr. Gaboni QHSC at gmail.com, and then those questions I'm going to share them with all the presenters. If there's any specific question from one hospital or the other, or the question from Dr. Gwen or for myself or for the QHSC, please let us know ahead of time. Don't feel shy, because we want to be able to address it and try to answer them before we get there. And then so when we get there, at least everybody has the same understanding, so we can do those skills as much as we can. We want to do more hands-on, because we know when you are practicing in this high situation, memory, you cannot rely on your own memory. And that's why we have those cognitive aids to say, okay, grab it. What are the stage 0, stage 1, stage 2, stage 3? We need to be able to do those things consistently. Every single person who comes to take care of that patient should do exactly the same thing to be able to take care of that patient. So then that is going to improve the patient's outcome. And that's our goal, because that mom needs to go back and take care of that baby. And we all choose that profession to make sure we save lives. So we need to do that, and you should be able to do that. And in between that, we need to make sure those NSG are clean and safe, as Mr. Nicodem taught us today and previously. So we're going to probably create a little what the little ID badge, we call them, to have those steps line up, and then everybody should be able to get that and be able to remember when you have those NSG, what do you need to do to secure them to where the serial processing or processing people do, and then so they can take care of it and make sure they're ready for the next person. And then those checklists will be shared with the when we send these links, and then please review them. And then if you have any question, let us know. There's some of them, maybe something might be done in US, but not in Tanzania. But then yes, you can transfer that or edit that and put your information there. Let us know. So if we need to fix some of the content, then we can make it applicable for you, because we want to make sure when we give it to you guys, you are able to use those items. As I said, we all agree, as what Dr. Gwen said, in America, we're doing things consistently, and it becomes mandatory, whether you like it or not. You have to be able to do it to make sure you're providing the basic care for patients. And so every single patient who shows up in Buguruni or Amana or Muhimbili or Mbanzira or Temeke, we get the same care, basic care. Yes, I know some of them levels are different, I understand that, but those are fancy stuff to add more acuity, that's fine. But basic care, that's what we're talking about. Every single person has to be screened. Okay, I have the risk factor, you need to be able to address that and prepare for my delivery before I start bleed, so you will know for sure. So, I mean, that was great discussion. Anybody has a last word, and then I will let you guys go. And thank you very much for staying a little bit longer. Anybody? Miss Vicky? Dr. Msambichaka,
No,
yes.
I just put in the chat. Good morning, everybody. I just put in the chat that this is a well-informed and very detailed discussion. I'm learning from you guys.
Oh, great. Thank you. Dr. Msambichaka?
Yeah, I echo Miss Vicky. I just wanted to say thank you, everybody, for your time. And this is I mean, I'm a pediatrician and internal medicine doctor by training, so some of this sounds foreign, but as a patient myself of severe postpartum hemorrhage, I really appreciate the fact that there was standardized care. The team came to my rescue, and I was able to survive and be here today with all of you. So this is life-saving stuff. It can happen to any one of us, any one of our family members, even as healthcare workers ourselves. And so I really just I want to appreciate all of you for your effort putting this together. And as a pediatrician, you know, a healthy mom is a beginning for a healthy baby. So thank you for saving the lives of all those moms, and so that, you know, they can take care of their babies and make all the pediatricians' lives easier. So thank you.
And thank you, Dr. Msambichaka. Mr. Siakabe?
Yes, just wanted to echo what everybody else was just saying. I want to give everybody from Tanzania a big asante sana, and that we look forward to working with you. It's what, in another 2 weeks?
Yeah, counting down.
Okay. So we are on our way.
Yes, packing the gun. Visa's ready. Yes. No, thank you for sharing that. Now, Miss Vicky. I know Miss Victoria spoke, but Miss Vicky.
I just want to say that preparation is the key. Just as we prepare to take care of these patients when they present to our units, then what we're expecting is that you're going to prepare to go through this simulated experience with all the information that we've shared, because we're going to go from step A to step B, from time the patient presents to the time the patient's transferred. So knowing how to put those garments on, also communication, how do you communicate from one facility to the other? All of those kind of things are going to be incorporated into the simulated experience. So study hard, okay?
No, thank you.
You're muted.
I know, I don't know why. Anyway, thank you, Dr. Gwen. That's exactly what I forgot to mention before. We need to know, like, how many people usually show up if you call for postpartum hemorrhage, the number of people, like individuals who comes with the different roles on that, taking care of the postpartum hemorrhage patient. Nicodem, do you know how many people, if you call for the postpartum hemorrhage?
People that could show up.
Yes, to attend the postpartum hemorrhage, yes.
Depends on the ward, but you could have 2 more plus you.
2 plus, okay, so so those are added to the midwife or the nurse who was delivering the baby, right?
Specifically, that is added to midwives, because most of the time who is available in the ward or in the labor ward is a nurse, is a midwife. The doctors and their other, maybe they could be in their office or whatever. They could come immediately. The midwives coming in.
Midwives. So and those are usually there are 2 of them, you said?
Yeah, 2 of them, and it depends on the shift. If it is a night shift, then you would find 1 more.
Okay, so I would say 2 to 3 then. Okay, so that without the doctor. So the doctor is going to be the 4th person.
Yeah, then there could be the 4th person if they are just called. Maybe the emergency, they just pop in.
Okay. For who do I have? Oh, Dr. Mugalu for Mwananyamala. How many people if we call for PPH event?
If you call for PPH event, usually most of the people around show up. So at the night shift, there's usually like 4 doctors in the obstetric and gynecology. So if you call for help, most of the doctors will be there. If there is no other responsibility elsewhere, like an operation going on, so every other doctor will come. And as for the nurses, it also depends on the shift. There's usually 3 in the labor ward, so there'll be 3, but in the antenatal ward and in the postnatal, they could come and show up. So usually maybe about 5-6 people could show in the daytime, and maybe a similar number at night.
Okay, so when you're saying people are showing up, I'm sorry, Dr. Gwen, when you're saying people are showing up, that we don't count the initial 2 people, the midwives who are delivering, actively delivering. When we call for help, nighttime, possible 4 doctors or whoever is available, and then daytime, 5 to 6 people added to the original 2. That's what you're saying?
Yes, yes.
Okay, so yeah, I'm trying to put the numbers, so 6 to 8, okay. Dr. Gwen, I'm sorry, go ahead.
Yeah, I was saying that they might want to think about team development, you know, what roles and responsibilities are, and, you know, how people function as a team and how they communicate as a team, rather than everybody just showing up and who's on first, who does what, you know, how do you know? And so all that also plays into, comes into play when you're talking about patient outcomes and making sure that things are getting done in a timely manner, and also who is responsible to do things, rather than people just showing up. You can have numbers, but numbers really don't mean anything if they're ineffective teams. So we really foster the team concept.
Yes, I agree with Dr. Mugara when she said the night people are at least 4 doctors. So then if you know, if the call comes, at least the first 2 should have the identify role. Okay, you're gonna run the code, you're gonna probably do scribers, or you're gonna do this, you're gonna do that. The nurse who is calling primary, usually they don't do anything as being primary for the patient. Then another person should be scriber, another person will be the runner. So all those roles have to be developed. Even if we are working on different units, when they call the code, you know your role, you grab and go. You cannot say, I mean, for doctors, probably somebody who's going to do surgery. So, you know, the surgery person who is going to surgery should be an added, not an assigned role. Unless he's the one who is, he or she's running, who's doing surgery, then you'll be the primary person for that patient. And then when you call the role, then other people will come in. So those are things that, yeah, we need to identify and make sure everybody knows what they're coming to. And those usually are assigned on the beginning of your shift. You show up, you start at 7 or whatever you guys time start. Then, you know, I'm going to be a scriber. So the event calls, then I have to run, grab my clipboard and start writing time, 12 o'clock, 12:01, 12:02, whatever, this medication given, this, because some of them are timed event, especially, for example, for help baby breathe, for example. That first minute, everybody needs to know what it is. And then eventually you guys will be able to learn how to do the medication for the baby. The same thing, time-wise is raw. The same thing for the OB, first minute, what do you need to do, all those stuff. And then, if it's 10 minutes, you're doing the same thing over and over and over, I think we are losing time, and patients, we are losing that patient. So we're gonna need to identify those roles and then establish the consistency on each role. Every single time you call, the bare minimum people can come should have that role. And then when you have extra people, yay, but bare minimum, these people have to show up for that event so people can have consistency. Yes, Dr. Mugaro?
Yes, I had an additional point on the calling for help point.
Mm-hmm.
I think we should keep in consideration what the previous speaker said about when we call for help, we should really try to involve the pharmacy people and the lab people as much as possible. It is of very importance, because we do have a cart, but time to time you find somebody forgot to replace the medication they took from the cart. So when the pharmacy people are involved, it could help in life-saving.
Excellent idea. Yes. Calling labs, because sometimes you do need the labs drawn for if especially a patient is bleeding or you don't know the blood type or RH type. You do need the labs people, and then also you do need the lab people for blood. The pharmacy, of course, medication dispensing, and as you said, somebody needs to know. So our card, for example, have the little sticker And then the nurse or the, we call OB tech, OB technician usually check those items every single shift. So to make sure the medication is when they're expiring. So if you don't use it today, tomorrow, that's on the cart, the last medication that is going to expire is right there. Sorry, the earliest medication is going to expire first. That's when it's going to be the last item on that cart. So then when you're checking it, it's expiring at the end of the month. Today is 2 days before the end of the month. We need to change that and then replace all the medication. So that part, we have to get to the point that it's that consistent, like every single time. We should not be surprised, like, oops, we opened, there's no medication. Do you want to call the pharmacy? It's nighttime, they're not there. So we can't rely on that one. But those are things that we need to be able to learn and develop and be able to build your consistent care. And everybody's going to be happy because when the doctor orders something, turn around, it's right there. And then so the patient's safety increases because everything is readily available for that patient. So that was great. So we're going to keep working on it. And thank you again. Everybody else have a last thing. Dr. Sangalala, any final words? Then we can let people go.
Thank you for the nice presentation. Currently, I was on and off because I was attending.
Uh-oh, we lost you. She disappeared. Okay, we're gonna let her back in if she can come back. But anyway, I just want to say thank you very much. Anybody has the final words, then we can let you guys go. Thank you. This was great learning opportunities. As I said, only 16 days. 16 days. We're coming. And thank you for your time, and continue asking you for your participation and help us be able to be more effective to make your practice a little bit easier. If there's something that we can do, please let us know. We try. We might not be able to do this in 2 weeks, but we might be able to try and do it, even if we come back from the medical mission. And we are hoping to continue these lessons and training and sharing your best practice from everywhere. And that's all we can grow. And learning is endless. Elimu haina mwisho, we know that. So we need to keep going. And thank you again, everybody, for being here.
Leo 16.
16 siku zimebaki. Bye, guys. Thank you.
Bye.
Bye.
Hey, have a good time.
Thank you very much, Mr. Nicodemia.
Bye.
Thank you.
Okay. Thank you, Hashim. Thank you, Dr. Mep. Thank you, Miss Vicky. Thanks to Dr. Mugabe. Bye, guys.